First of all, I would like to thank the organizing committee for making me the part of this academic feast. So I'm Associate Professor in Safdarjung Hospital and Executive Member, Family Welfare Committee, FOXY, Vice President, IMS South Delhi Branch, and Chairperson of Infertility Subcommittee, AOGD. So I will be talking today on Ionosator and Pcos, evidence and recommendations. So I'll be starting my talk with a brief introduction to PCOS, followed by the role of insulin in PCOS, the role of inositols in PCOS, then what is the evidence till date and what are the recommendations. So PCOS, as we all know, is the most common endocrinopathy in the women of reproductive age. It is a complex condition and presents with a wide spectrum of signs and symptoms from oligomenorrhea, infertility, to hyperandrogenism, hyperinsulinemia, associated comorbidities, type 2 GDM, gestational diabetes, metabolic syndrome, and cardiovascular disease. In fact, the PCOS patients have 7.4 times higher risk of developing MI, increased risk of diabetes, and 42% of these patients also been reported to have cardiovascular diseases. If we go for the diagnosis of PCOS, by the NIH criteria, which came in 1990, it said that hyperandrogenism and oligomenorrhea, they both are required for diagnosis. But then Rotterdam consensus criteria came in 2003, which stated that 2 out of 3 are required for diagnosis. That is hyperandrogenism, oligomenorrhea, or PCOS, any 2 out of 3. Whereas Androgen Access Society in 2006 made hyperandrogenism as mandatory requirement for making the diagnosis of PCOS. So if we see in today's era, we are following the Rotterdam criteria. Now the use of this Rotterdam criteria is that we are able to diagnose even those patients as PCOS who have ovulatory function along with polycystic ovaries and also hyperandrogenism with polycystic ovaries. So these are the 2 phenotypes which won't be detected if we go by the NIH criteria of 1990 and will get missed. So we are following Rotterdam criteria so that we can maximally diagnose PCOS and prevent its complications. Because as we know, in PCOS, we have to have a targeted approach to the patient's primary complaint, whether it is infertility, whether it is reduction of clinical manifestations of hyperandrogenism, restoration of regular menses, or prevention and treatment of associated comorbidities, obesity, insulin resistance, type 2 diabetes, or dyslipidemia. So if we see insulin, it has main 2 functions. That is, one is promoting the glucose cell uptake, and second is the glycogen synthesis. Now, insulin, it binds to the receptor and forms the insulin receptor substrate, which stimulates PI3 kinase, which will activate GLUT4. And finally, we have the glucose channel open through which there is intake of glucose into the cell. So this is what is occurring in a normal female. And now if we see metformin, it stimulates PI3 kinase, and this metformin has been used since ages for reducing the insulin resistance. Now we have myoinositols. So if we see inositols, they are acting as second messengers in the insulin action. MI, it promotes glucose cell intake, whereas dichloroinositol, it stimulates the glycogen synthesis. So accordingly, they are found in the tissues. As DCI is stimulating glycogen synthesis, so it is found in high concentration in glycogen storage tissues, that is liver, muscles, and fat, whereas it is found low in the tissues needing elevated energy levels, that is brain, ovary, and heart. So MI is to DCI ratio in different tissues is critically important and will determine how that tissue is going to respond or does not respond to insulin. So if we see myoinositol, it is the most common form. 99% of inositol in the human tissues is myoinositol, and it enables insulin and FSH signal transduction in ovary. So not only it is enabling the insulin action, but it also has an action in the ovary, that is FSH signal transduction. So at both the sides, it is acting as a secondary messenger. Similarly, if we see dichloroinositol, although it is only 1% in the human tissues, it's required for, again, the insulin actions in peripheral tissues where there is glycogen synthesis. And it also stimulates testosterone production in ovaries. So now when we go to PCOS, in PCOS, if there's a deficiency of ionosator. So if we see this was a study which showed that the PCOS patients had a very low level of inositols in their serum, because 5 times more urinary clearance of inositol is seen in the PCOS women. So now, if there is inositol deficiency, the insulin actions which normally occurs, and these act as secondary messengers, will not occur. So there will be decreased PI3 kinase activity, decreased GLUT4 activity, and decreased intake of glucose in the cell. Similarly, because of dichloroinositol deficiency, glucose will not get converted to glycogen. So there will be decrease in the conversion. So what will happen finally? There is going to be increase in the blood glucose, because it's not getting absorbed into the cell. Also, it's not getting converted into glycogen because of MI and DCI deficiency. So hyperglycemia will occur, and this hyperglycemia will lead to increase in the insulin levels, so hyperinsulinemia. And also, if we see this MI to DCI conversion, it is epimerase dependent, and this epimerase enzyme is insulin dependent. So now there will be excess insulin because of the deficiency. So there will be excess insulin in the ovary. It is going to trigger epimerization. That is, more of MI will get converted to DCI. And if you remember that in ovaries, we need more of MI rather than dichloroinositol, because myoinositol is required in the places where there is more of need of glucose, more of need of energy, whereas dichloroinositol is required in the places where there is conversion to glycogen. So in the ovaries where we require more of myoinositol, because of the increased in insulin levels, because of increased insulin, because of more epimerization, we are ending up with having more of dichloroinositol. And as talked earlier, dichloroinositol, it leads to increased testosterone levels in the ovary. So insulin resistance is also occurring, and that too, it is independent of the body fat and is seen both in the obese and lean PCOD. So if we see the PCOS women, the insulin resistance is very high. Epimerase activity has been triggered, and due to this activity, this physiological normal ratio of 40:1 of myoinositol and dichloroinositol is disturbed, and now there will be more of dichloroinositol. So this occurs, which is called the DCI paradox in the ovary. That is, the required thing, the myoinositol, which is involved in FSH signaling, is decreased, and DCI, which is required in a very less amount there, its function is mainly in the tissues where there is glycogen synthesis and storage. There, instead of that, the DCI is increasing in the ovaries, and which is responsible for insulin mediated testosterone production. So net result is increased DCI in the ovary. We talk, there is increased DCI, which promotes androgen synthesis, and myoinositol depletion, which will worsen the energy states of the oocytes and impair the FSH signaling. So all these events taken together will not only leading to insulin resistance, but hyperinsulinemia, epimerization, more conversion in the ovary to DCI is finally leading to impaired FSH signaling and poor oocyte quality. So now, could these inositols be considered to treat PCOD? Inositols, if we see, are a part of diet. They are 6-carbon sugar alcohols commonly found in fruits. In grapefruit, it's the highest, and in leafy vegetables, it's the lowest. It's found in all food containing seeds, basically beans, almonds, and walnuts, it's the highest. So the trials have been conducted since 1999. The first trial was conducted in US, but what they did, they used DCI alone and they did not get good results, so they stopped conducting the trials and thought it not to be useful. But then the ball was in the European court and they decided to do the further trials, and they initially focused on only myo-inositol. So the results were encouraging. It started from early 2009 and they did many studies were done which used only myo-inositol with encouraging results. It showed significant disappearance of hirsutism, acne, significant reduction in both total and free testosterone levels, and over 3 to 6 months in several studies, both the metabolic symptoms as well as the testosterone levels were found to reduce. So myo-inositol decreases both insulin and BMI. They did it with comparison with placebo as folic acid. Then insulin sensitivity, HOMA index, they were also found to be significantly improved. Also, the clinical pregnancy rate and delivery rate were found to be better with myo-inositol. So this continued, many studies were done and all had encouraging results. So this was a study of recent in 2019. Now they were comparing it with metformin, the drug which has been used since ages. And what was found that both used to give good results, but metformin, there was an increased risk of adverse events, basically gastritis. If we see myo-inositol, it was better tolerable, more acceptable for the recovery of androgenic and metabolic profile in the PCOS women, which made myo-inositol the drug of choice. And further studies were conducted. Now, what was happening that they were using MI alone, but then the studies started by using the combination of MI and DCI. But now the goal was to find out the correct ratio in which they should be used. So several studies were done. And if we see in 2012 also, they did with various ratios and finally found 40:1 as the correct ratio to use myo-inositol and dichloroinositol. There was improvement in total testosterone, sex hormone binding globulin, improvement in plasma glucose, insulin concentration when compared to myo-inositol alone. And they definitely found, the other studies also, they definitely found MI and DCI in the ratio of 40:1 to give very good results. So with the combination therapy, a significant improvement was seen in the lipid profile, BMI, waist-hip ratio, blood pressure, and the HOMA index. This was the study in 2016. Again, they found very good results when they used MI plus DCI. The recent study in 2019 also found the encouraging results. They used various ratios, 40:1, 20:1, 80:1, 2.5:1, 5:1, and they also concluded that 40:1 is the best ratio to get the maximum good results. Thus, the combined treatment in physiological ratio of 40:1 is able to restore both hormonal and metabolic parameters in the overweight PCOS women earlier than with MI alone. So this is what the evidence has to say, and the rationale behind this 40:1 is that it is a physiological ratio. which is normally present in a healthy human being. So now, if we are thinking to use something, we should know its safety profile. Let's look at the evidence. What is the safety profile of ionosator? So these various trials which were done, they never found any side effects. No side effects have been reported till date, except a mild GI discomfort, which can be nausea, flutters, diarrhea, that's it. In fact, it is found to be not only safe in pregnancy, but beneficial, as it reduces the chances of neural tube defects and leads to improvement in gestational diabetes. So this was a safety profile regarding study done in 2019, and they found that it lowered the rate of GDM and also lowered the preterm delivery rate, and no adverse effects were reported. So coming to key points are that MI and DCI, that is myoinositol and dichloroinositol, it plays a key role in insulin receptor signaling. And if we talk about ovary, then low levels of myoinositol adversely affects the ovarian function and egg quality, as it has the effect on FSH signaling. And elevated levels of DCI in ovary causes increased androgen production. So supplementation of 40:1, that is the physiological ratio of myoinositol is to dichloroinositol, improves the metabolic endpoints in PCOS women. Also, it restores ovulation and improves the fertility in the PCOS patients. This is what the evidence has to say. Now let's see what the recommendations have to say. If we go to ASHRAE 2008, it says that myoinositol can be evaluated as the primary method for ovulation induction in PCOS women. 2012, ASRM said that myoinositol treatment should be routinely introduced in the IVF protocols. But now if we see international evidence-based guidelines for the assessment and management of polycystic ovarian syndrome 2018, that is the recent guidelines, it says that ionosator should currently be considered an experimental therapy in PCOS with emerging evidence on efficacy, highlighting the need for further research. So we have evidence with us, but yes, it's still we need more research, we need more evidence, and we need research to be done on a lot many more patients so that it can come in the recommendations. Thank you.